Hello everyone, good afternoon. My name is Dr. Sneha Balki and I welcome you all to yet another session of our Facebook Live. And today we are going to discuss an important topic related to fertility. So, we all have heard about laparoscopies. So, what is the role of laparoscopy or gynec endoscopy when there is infertility treatment ongoing? So, first of all, let's understand the basics about it, basics of reproduction. So, usually it is uh, a conception on the part of the couple that if the egg count is good or the AMH is fine and the sperm count is good, the motility is good in the semen analysis of the husband, then there shouldn't be any obstacle while conceiving naturally. So, many a times we often forget that the conception or the fertilization of the egg is going to happen only if the tubes are open or the tubes are functioning. So, fallopian tubes, which are attached to the uterus, are an important organ which, when they function well, only then it does help us in conceiving naturally or with IUI methods. So, it's very important if the tubes are functioning or not. Many other factors are often overlooked, such as if there are any ovarian cysts or there are any factors in the uterus where the pregnancy is supposed to get implanted. So, all these things are somehow not given that due importance, and hence it's very important to assess those things also. So, what is laparoscopy and how does it help when we have to assess all these things apart from just the AMH or the semen analysis? So, what is the role of laparoscopy during the treatment of infertility? So, laparoscopy or hysteroscopy are basically some minimally invasive surgeries which are daycare procedures, and they are basically involved in taking a look at your reproductive organs. How does it work? So, minimally invasive, what does it mean? Or daycare, what does it mean? So, when a lady is posted for a laparoscopy or an endoscopic procedure, we admit her on the day of the surgery early in the morning. We do the surgery, which often doesn't take more than half an hour to 1 hour at the most, and it has a minimally invasive technique, which means that the incision for this surgery, although this is a surgery, but the incision or the stitches are very small. Often it's only about 5 to 10 millimeters big. So, this is what it means by minimally invasive, where we use a pen size camera which is inserted inside the abdomen or inserted through the vaginal canal, and a detailed view of the uterus and the tubes, ovaries, and overall internal reproductive organs are seen and evaluated to rule out any causes for infertility. So, this is what is minimally invasive gynec endoscopic procedures such as laparoscopy and hysteroscopy. It is again a daycare procedure. So, a daycare procedure is basically when you get admitted in the morning of the procedure, and by the evening time, by the end of business day, you get to go home where you are walking on your own. You have already regained your consciousness and you can resume your day to day activities and your routine, your job, everything you can resume exactly from the next day onwards. So, this is what it means by a daycare and minimally invasive surgery. So, there are two types of gynec endoscopic procedures. So, there can be either diagnostic procedures or operative procedures. Diagnostic means we do the procedure, we see that there is some issue over there in the reproductive organs, but we do not do anything to treat them, and we come out and we end the procedure then and there. So, a diagnosis is made. Operative procedure, on the other hand, we know that there is some diagnosis of some abnormality in the reproductive organs. We go endoscopically, and we treat the procedure. Often, what happens is a diagnostic procedure solely for the purpose of diagnostic is not routinely used nowadays because there have been such advances in your ultrasound. So there are many machines and many 3D ultrasounds which can be done, which give us a pretty detailed picture of the things in the reproductive system. So often a diagnostic procedure for gynecendoscopy is avoided. Only if it's supposed to be therapeutic or surgical procedure, then we go ahead for your hysteroscopy or laparoscopies. So a see and treat approach is what is being followed nowadays, where if some diagnosis is made during that procedure, the diagnosis is then and there settled, and the treatment is also done in the same sitting. So this is what is being followed right now. So when is laparoscopy or endoscopy, hysteroscopy indicated if you are undergoing infertility treatments? So specifically, if we see that laparoscopy or endoscopy is the norm nowadays, and daycare minimally invasive surgeries have taken over and have been replaced, and they have replaced the traditional conventional surgeries. So, all the surgical techniques that can be done or they are needed for uh, other disciplines also, like gastrointestinal surgeries or gallbladder surgeries. So similarly, reproductive tract also has some indications where laparoscopy does help, such as if a lady is suffering from heavy menstrual bleeding or irregular menstrual cycles, a lady has polycystic ovaries, or there are ovarian cysts which are not resolving with medications. Third thing is if there are some fibroids, or if there are some growth or tumors on the uterus. If the uterus itself has grown big and a hysterectomy is planned for the lady, even that can be done with the help of gynecendoscopy. So, such many indications are there, but specifically today we are going to talk about what are the indications of laparoscopy during the treatment of infertility. So, we are going to focus on only infertility treatment right now. So, when and what are the situations or what are the things that can be treated with the help of a gynecendoscopy? So, let's go from level 1 and above. So, basic hysteroscopy is when a vaginal camera or scope is passed and we visualize the cavity through that scope. So, there involves visualization of vaginal canal, internal vaginal canal can be observed, cervical canal can be observed, and the uterine endometrial cavity also can be seen. So, first and foremost, vaginoscopy. There are many cases which come to us where the lady suffers dyspareunia, which means the coitus, or when she keeps relations with her husband, the coitus is painful. So there may be various, oftentimes it is mostly psychosexual, but there might be some cases where there is a organic component to that as well. There can be some vaginal septums, there can be some adhesions, some infections which give rise to dyspareunia also. So such things can be diagnosed very well on a vaginoscopy. That is examining the vaginal canal through your hysteroscope. Another thing, similarly, there can be some reasons for dyspareunia in the cervical canal also. So, cervical canal, if there is a septum of, or there is a partial septum is there, or a transverse cervical septum is there, or suppose there is some cervical ulcers or some cervical erosions are present, which are harboring some infections, even those can be visualized in depth during a hysteroscopy. Another thing that we observe is sometimes the cervical canal is tightly closed. So, cervical adhesion, cervical strictures can also be present, which can be broken while negotiating a hysteroscope. Once we are inside the cavity of the endometrium or the uterus, there are many things that can be seen and treated during a hysteroscopy, such as if there is presence of a fibroid, which is inside the cavity of the uterus. Another thing is if there are some polyps which are localized hypertrophic endometrium. So your endometrium is growing rapidly at some places as compared to other places. So this gives rise to polyps which might interfere with the implantation of a pregnancy. So such polyps can be seen and treated in the same place during a hysteroscopy. Another point which can be treated is thin endometrium. So often in IVF, we see that during a stimulation or during a treatment of IUI or IVF, we see that the endometrium is not growing up to the mark. Hence, it avoids a successful and healthy implantation of the embryo. In this scenario, often doing a hysteroscopy gives the necessary stimulus to the basal endometrial cells during endometrial scratching or metroplasty. So, this leads to a healthy endometrium growing in the subsequent cycles because it increases the blood flow. And sometimes we also couple this treatment along with PRP installation. So PRP is platelet-rich plasma, which again influences your basal endometrium and gives rapid growth because of concentrated localized inflammatory mediators. So this is also something which does help in a thin endometrium, which we might encounter during an infertility treatment. Apart from this, there are some congenital or uterine anomalies which are probably diagnosed early on during your 3D ultrasound. And for the treatment of those anomalies, we are going ahead for a hysteroscopy, such as an unicornuate uterus or if there is a uterine septum. So, such things we can go inside the uterine cavity and the cavity size or the septum we can dissect and take out, which we call as septal resection, and the cavity size can be enlarged from the inside, which we call as the metroplasty. So such things are treated during a hysteroscopy. Apart from this, it's very important that although the ultrasounds, the 3D ultrasonographies have advanced a lot in the past few years, even so, they are still a little less in diagnosing and uterine infections. So, intrauterine infections are something that can be visualized only when you do a hysteroscopy under vision. So, under vision, we can diagnose whether there are some signs and symptoms of some chronic or acute infection present in the endometrium, and we can take a sample, take a biopsy from the suspected lesions or the suspected areas, and those samples can be subjected for a culture where we can find out what type of infection it is and give adequate treatment for the treatment of those infections. So these things are something that can be treated very well by a hysteroscopy, which contribute to some factors which cannot might not be diagnosed from the outside but can be diagnosed definitely during a hysteroscopy. Now, apart from that, as we hear that yes, laparoscopy is a gold standard test for checking your tubal patency. So, whether the tubes are open or not can be very effectively checked by doing a laparoscopy. So, during laparoscopy, what we do is we insert these cameras through your abdominal cavity along with a cannula from the vaginal canal, which helps in inserting the dye. This dye, then we check whether it's going through the tubes and falling outside the tubes or not by means of your laparoscopy. So, laparoscopy is going to give you a very clear idea of whether the tubes are open or not. If the tubes are found to be blocked, then what is the level of blockage present, even can be diagnosed quite precisely by means of your laparoscopy. Even here, there is see and treat policy, and if at all a blockage is diagnosed during a laparoscopy, we can cannulate those blockages and try to open the tubes in the same seating. However, only for checking whether your tubes are patent or not. We do not recommend a diagnostic laparoscopy just for the sake of it. So, if there are no other indications for a laparoscopy, we try and avoid it because there are better modalities available to check whether your tubes are patent or not, such as HSG and SSG, which do not involve even this much invasiveness. So we can get your tubal patency checked by means of an HSG or an SSG also, unless there are some other indications for a laparoscopic procedure. In that scenario, we can definitely go ahead and check your tubal patency during your laparoscopy itself. So many a cases we see that during an ultrasound itself we are able to see that the tubes are enlarged, the tubes are swollen, there is collection of some water or they are infectious. In that scenario, sometimes keeping the tube or retaining the tube in your body is not going to help much. Rather, it might interfere during our IVF procedures also. So, because of this interference, we tend to favor removal of these damaged tubes, because if a damaged tube is held within the body, it's not going to contribute in your fertility, but the infection present inside your hydrosalpinx might come down to the uterine cavity and lead to some embryo toxicity and hinders with your implantation also. So in presence of a hydrosalpinx or a pyosalpinx, we can go ahead and do a laparoscopic removal or clipping of the tubes to avoid this infectious material from coming down into the uterine cavity. So this is where the laparoscopy is going to help. Another thing, when now from tubes we go on to the ovaries. So in ovaries, what are the situations where we are going to ask you or suggest you to go for a laparoscopy? So there are many conditions, but primarily during infertility treatment, if at all we are seeing a persistent ovarian cyst, if there is an endometriosis, or if there is PCOD. So these are the three situations where, because of ovarian causes, we suggest a lady to go ahead for laparoscopy. So in case of a persistent ovarian cyst such as endometriosis, which is hampering the development of a healthy follicle, in that situation, we advise to go ahead for a cystectomy, where the normal ovarian tissue is retained in the body, but this damaged cyst part is what is removed by laparoscopy. However, a word of caution here, that during an ovarian cystectomy, your normal ovarian reserve also comes down a little bit, because the ovarian cyst wall also carries some amount of healthy ovarian follicles which might participate during your fertility journey. But because of the presence of the cyst, if there is a hindrance in the rupture of those follicles or the development of those follicles, it's better to get those removed. Another thing is why PCOD. So PCOD is a situation where the ovary is unable to produce a dominant follicle on time, and sometimes the dominant follicle, even if it develops, it's unable to rupture because there is a lot of stroma or a lot of tissue which doesn't have which doesn't contribute in developing a healthy follicle. So in this scenario, in order to reduce the severity of PCOD, there is a modality known as PCO drilling. So, ovarian drilling is something that can be done to reduce this stromal tissue, and henceforth, the subsequent cycles have been found that there is a better recruitment of a dominant follicle, and the dominant follicle also responds better to your ovulatory triggers, and there is a successful and better ovulation seen after PCO drilling has been done with the help of laparoscopy. So these are the factors where laparoscopy does help. Now, there is one important situation which is endometriosis. Like we discussed, some infections are there which cannot be seen during your ultrasound, which can be seen only by your naked eye or are only under vision. So another thing that can be seen only under vision is mild to moderate endometriosis. So endometriosis is something where the endometrium, rather than getting expelled out during menses, comes back and gets implanted at different places and bleeds later on during your menstruation. So this endometriosis, if it is in mild to moderate severity, it is not seen or not picked up on your ultrasound, because it so far it hasn't caused an ovarian endometrioma, or a chocolate cyst is not formed, or there is no adenomyosis, but some amount of endometriosis is still present, which might be causing some delayed spillage in the tubes, some amount of blockage of the tubes. It might be disturbing the tubo-ovarian relation. So, in order for a successful ovulation and that ruptured egg to be picked up by the tubes, there needs to be a good relation or physical proximity of the tubal opening with the ruptured egg is essential for that egg to be picked up. This tubo-ovarian relation, which normally is always present, might be disturbed because of presence of some endometriosis, which leads to adhesions. So these things can be seen and diagnosed only during a laparoscopy. So, some mild to moderate degree of endometriosis, if it's diagnosed during a laparoscopy, we can always go ahead and dissect those adhesions and restore this normal tubo-ovarian relation, so that the subsequent cycles we can help the subsequent cycles by helping in the follicle rupture and the follicle being picked up by the tube. So these are the things where a laparoscopy is going to help you. Now, what to do after a laparoscopy? So, okay, fine. Laparoscopy has been done for either of these reasons, for some indication or the other. A laparoscopy or hysteroscopy has been done. Now, how do we proceed after an endoscopic procedure? What are the indications of your fertility treatment beyond that? So, after a laparoscopy has been done and we come up with some concrete evidence of probable cause of your infertility, we go ahead and treat that. Suppose there is a fibroid, we go ahead and remove that fibroid. Supposing there is a septum, or there is thin endometrium, or there's some infection, we go ahead and treat that problem. If there is an ovarian cyst, or if there is PCOD, we have taken out that cyst, or we have done a PCO drilling. If there is some tubal blockage, we have gone ahead and done a cannulation to open those blockages. So after this, after due treatment of your contributory factor for infertility, we can boost your fertility and help by following with 2 to 3 cycles of IUI in the subsequent cycles. Because many a times what happens, the positive factor has been found and it's been treated, plus the procedure itself gives a boost to your reproductive organs. Many a times the flushing medium that we use during the hysteroscopy or laparoscopy helps in removing minute blockages which might have been present in the tubes, and the subsequent cycles have a better chance of you conceiving with the help of IUI. So after laparoscopy, it is always advised to go ahead for an IUI for the next 3 to 4 cycles. Now, what are the scenarios where a laparoscopy is not going to help, or what are the situations where you should not take decision to go ahead for a laparoscopy just for the sake of it because you have done everything else? So, if there is some other contributory factor for an infertility. So, other contributory factors such as if everything is good, but only we have to check for your tubal patency. We need not go straight away for a laparoscopy because there are other modalities available which can also very reliably tell us whether your tubes are patent or not. So another factor is if there is severe male factor, like the husband's semen analysis is not good with less sperm count, or if there is some infection in the husband's semen, or there is less progressive motility, and we can obviously see that okay, this might be a more probable cause of your difficulties in the fertility. In that scenario, we have to focus more on that rather than just going ahead for a laparoscopy. Along with this, if there is poor ovarian reserve or the ovarian reserve is dropped, the AMH is low, in that scenario, just doing a laparoscopy is not going to help you, and you might be headed towards IVF, where you have the probability of having a better success rate and better result. So in these scenarios, we do not advise you to go ahead for laparoscopy because there are other modalities available such as IVF and ICSI, which when used properly, depending on the causative factor of infertility in that particular couple, we can give better results by doing an IVF or ICSI rather than just going ahead for a laparoscopy. So this is all about laparoscopy and its indication during a fertility treatment. If there are any questions pertaining to this topic, we can start the question and answer sessions. So there's one question right now. Will laparoscopy improve my chances of getting pregnant naturally, or is it more useful for planning other fertility treatments like IVF? So this is just what we discussed right now. So what happens in laparoscopy is many a times your ovulation cycle gets restored, your thin endometrium gets treated, the flushing medium removes any tiny blockages that might have been there in the tubes. So all these things, if those were the factors and we are able to pinpoint, okay, this was the probable reason behind your infertility and that's being treated, we can expect you to conceive naturally or with the help of IUI in the subsequent 3 or 4 cycles. But in spite of your 3 or 4 cycles post laparoscopy, there hasn't been a conception. Or if there are other factors which we are thinking of to be more likely because the reason for your infertility, such as male factor infertility, or if there is poor ovarian reserve, or if in that scenario some unexplained infertility is there, like everything is fine, even the laparoscopy is fine, but in spite of that there is no conception happening, we might be able to give you better results or better successful pregnancies with the help of an IVF. So it's a very subjective thing where the couple's findings or their reports and their other factors such as the age of the couple, the age of the female in the couple, the duration of infertility also help us in arriving at a decision whether to offer laparoscopy or to offer other modalities such as IVF. So another question is, can laparoscopy help me with conditions like endometriosis or fibroid that might affect my fertility? So endometriosis, the diagnosis of endometriosis, if it is a severe grade endometriosis, can be done ultrasound with the help of ultrasound. But if it is a mild or moderate endometriosis, laparoscopy is the gold standard for detection of endometriosis. So if we do find some signs of endometriosis during a laparoscopy, we can go ahead and we can cauterize the spots of endometriosis present inside, which we want to down regulate those endometriotic spots so that they do not bleed again in the next cycle by giving some hormonal treatment for the subsequent 2 or 3 cycles, which will help in controlling the endometriosis. Apart from this, fibroids. If yes, fibroids are present and they are large, but they are located outside the cavity, they are outside the uterus and are not going to interfere with your implantation, we can safely ignore them. And however, if the fibroid is larger in size, or if it is located in such a way that it's going to disturb the endometrial cavity at the time of your implantation, then yes, laparoscopy is your go-to treatment and you can effectively get them treated by laparoscopic myomectomy. I think this is the end of the question answer session. If there are any further queries related to your fertility treatment, or if you are someone who has been advised laparoscopy, you can connect on the helpline number that's given below. This is me, Dr. Sneha, signing off from today's Facebook Live session. Thank you.